Good evening, everyone. So the last I saw was India was 72 for 2 between the India and Pakistan match. Pakistan was 72 for 2 and India is playing well. The predictability is 68 versus 32 is what I saw it last time. Just wanted to give an update. So
you
thank
just
you,
manufactured that,
AIOS.
Shrinivas. I'll tell you, you just manufactured that.
Yeah, so by the end you can again update the score. Dr. Anurag, thank you for that wonderful introduction. Thank you so much for that kind words. So I'll be speaking about how to go it. Okay. What's happening? It's not moving. Huh?
Ma'am, the
Okay.
whole conference is...
You're able to see this video. 1 second. Okay. So as we all know, the multifocal IOLs are often discouraged in the patients with or at risk with the retinal disorders. Diseases can include diabetic retinopathy, age-related macular degeneration, epiretinal membranes, and it's also believed to reduce the contrast sensitivity. But let's look into some of these videos. So this was the case where I was always telling that yes, multifocal IOL can be done and retinal surgery can be done in any case of multifocal IOL. So this was the case of bad retinal detachment in a case of multifocal IOL. Now you can see the PVR over the disc, and not just that, even there were subretinal gliotic bands as well. So I had to do a small retinotomy and then take away those subretinal gliotic bands. Do anywhere you see that there is blurring? No, I did not see. I did not see the blurring anywhere, and the surgery went very well. So I started advocating that no, multifocal IOL retinal problem, especially for the surgeries, it's definitely not a problem at all. Then recently I came around with another case where I had to do a epiretinal membrane, in this case of multifocal IOL. Now you see this, the round rings beautifully seen. So this was the case of IFIL grade 5, what we call it as. Now if you see here, yes, it was coming well. You see the ERM epiretinal membrane came very well. Now you see this ghost-like images. Do you see the forceps? Yes, it was looking blurred. So I had to refocus, focus again, refocus, focus again. So it took a little bit of time for me to do this. Now, this is my favorite where I try to do it in monochrome. That is a black and white technique where the blue visualization of the ILM comes very well. Now you see here I am trying to remove this. It was coming well, but again I had to refocus it because you can see those ghost-like images, what was said in the research papers. But surgery went well. It's not like it's going to be anything difficulty, but there is some difficulty. Yes, it is faced by the retinal surgeons with the patients with multifocal IOL. So this was the next, this is something called as the use of dark adaptation to screen before the multifocal IOL explantation and identifying the patients with early AMD to avoid suboptimal surgical outcomes. So this is something called as the ADAPT DX adaptometer, where it was approved in 2014, and it's test for the easy for technician. It can detect subclinical AMD at least 3 years earlier than it is clinically evident. Now let's look into cost effectiveness of pre-operative OCT in cataract evaluation for multifocal IOL lenses. I think it's a yes. There is no doubt about it. There is no controversy, no debate or anything. Any patient undergoing a multifocal IOL should get a pre-operative OCT at a must, because the OCT increase the detection of the macular pathologies and improve the qualis over the time. So let's look into these case examples. 61-year-old software engineer, bilateral drusenoid PED, right eye multifocal IOL. Now what to do for the left eye? Yes, you people have so much in the market, and you see, you do all, I've seen such a beautiful videos operating by all the cataract surgeons here. So what to choose, how to choose? IOL selection for the patients with age-related macular degeneration, the stage of the disease must be considered. Now, if you see here, patients without clinical evidence of macular disease, but like there is no drusen, no pigmentary changes, just having a family history is definitely not a contraindication. He's a normal patient, he's a candidate of all kinds of multifocal IOLs. Patients with early maculopathy, like patient who has soft drusen, pigmentary changes with relative sparing of the lens visual acuity, I call it as a difficult counseling. Not an absolute contraindication, not an absolute indication, but it's a kind of difficult counseling. But however, patients with moderate to severe AMD, where you see the drusens, large drusens with geographical atrophy or exudative changes already happening in those patients, then definitely it's a no for the multifocal IOL. The patient will be really very unhappy. Now, These are the pros and cons. I need not tell about all these things, but let's look into this. Would you implant a multifocal IOL in a patient with age-related macular degeneration? The author said that they are losing their independence, their ability to read. Often they are no longer able to drive or to engage in activities they love doing. Several articles have listed even depression as something not uncommon among the patient with AMD having the multifocal IOLs. Now, what is the lifespan of the people in India? Say around 60 years. Now it's come to 70 years. Earlier, if now you see United States and Canada, it's almost matching. Now, why I am telling this lifespan? Why I have included this into this picture? If you see the demographics of the wet AMD and the demographics of geographical atrophy, it's only 8.2% of the patient who actually undergo that is more than 80 years. And in geographical atrophy, it is 7% of the patients who are again more than 80 years. So the question debate arises here is, only for 2% of the patient, that is from 60 to 80 years if you catch, for 2% of the patient, why do you avoid putting a multifocal IOL in these kind of patients? So short-term outcomes, combined pars plana vitrectomy, epiretinal membrane, phacoemulsification surgery, it's all showing that yes, it can be done, multifocality was achieved. Scenario 2, wet AMD or geographical, if a patient already has a wet AMD with a multifocal IOL, definitely there is plethora, like how you people have intraocular lenses. The retinal surgeons have a lot of things into the market with a lot of biosimilars coming up, with a long-end technology biosimilars coming up. Now this is something interesting called as the nodal vision, which is the artificial intelligence called as the home-based OCT. It's the first of its kind artificial intelligence enabled digital diagnostic for the patients with neovascular AMD. So what it does, it takes around 10 pictures per day, and in case there is any fluid activity or anything, it pings the doctor directly, telling that there is an activity, and the doctor calls the patient, come back, take the injection, and then go back. So that's the kind of technology we are just entering through. AI-based nodal OCT analyzer successfully tracks exudative AMD. And then last scenario, if there is a bleed at the macula, then definitely biome versus contact lens is the question. Diffractive multifocal intraocular lens interferes with the intraoperative view, which I showed in the first two videos. These are the something which they call the arc-shaped images or the ghost-shaped images which are being seen. But how do we get out of it? Especially when you coat the anterior and the posterior surface of the IOL with a viscoat, then most of these effects are lost, is what is being described by the authors. And this is how you see without having putting the viscoat, and post you see the right side using a viscoat, it does give a better view. So lastly, I want to quote this study, multifocal, by one of my senior colleague, Dr. Andrew Gibrowski. He said that we were unable to find evidence suggesting that the patients with macular disease should be advised against multifocal IOL. Several contraindications for multifocal IOLs in patients with retinal disease have a hypothetical character and are not evidence-based. More research is needed, especially to address the effects of the multifocal IOL on contrast sensitivity, visual functions, patients' activities such as orientation, mobility, and various other things. So thank you very much. I think these are few of the points which I just wanted to bring upon in cases with multifocal IOLs and the retinal pathologies. Thank you.
This is called people getting engrossed with the talk, Shrinivas. They even forget to take your pictures till you're finished.
Thank you very much.
So essentially what the point you're trying to make here is the multifocal IOLs are not a no-no in the presence of macular pathologies, which might need treatment later on, either surgically or non-surgically. Is that the point you're trying to make?
Patients who have moderate, see now the debate is normal patients who has family history, I think they are all like the normal patient. Now if they have a small drusen, now if they are the patient with hard exudates but no evidenced diabetic macular edema on the OCT, I have seen few of the surgeons telling that no, you are a diabetic, I don't want to give it. Okay. You are a diabetic, I don't want to put a multifocal IOL, thinking that it will cause trouble for the future, or telling that some retinal surgeons might have complained that doing a laser might be difficult and all those things. But now we have entered into the era of anti-VEGF modality, where the lasers, especially the focal lasers, have come down. Of course, the PRP is there, but when we put the contact lens with the viscoat, as I said, all those ring effects, what the diffraction which causes, I think that all goes off very well. I have tried it. That's why I showed the videos before. In one video, the peripheral visualization is absolutely no problem at all with the multifocal IOL. Especially when you want to do a very fine focus surgery like macular surgery or ILM peeling. In those cases, there can be a little bit of that images, what they described earlier as ghost image, arc-shaped images might come in. But definitely with the advancement in the visualizations, it's not difficult anymore.
No, but this whole thing is cocooned into the vitreoretina surgeon's perspective. Let's talk about the patient's perspective as well, because you follow them up more closely and more vehemently than we do. After cataract surgery, it always is the VR surgeon's chamber that we direct the patient towards. So how far have you seen patients complaining with regards to their vision, the quality of vision they receive after a multifocal IOL implantation vis-a-vis a monofocal IOL implantation? How far the quality of vision and how much of that would you attribute to the IOL that has been implanted?
To be very frank with you, in fact, I have seen many patients complaining who are almost having normal retina. They are the unhappy patients, like unhappy 6/6 patients, still telling that I am not seeing, I am seeing something else, I am seeing glare and all those things. To be very frank with you, retinal patients are very kind.
And why were those unhappy patients with a normal retina sent to you?
Because think that
Because
there is
they
a
were
retinal
unhappy.
pathology to look if there is a cystoid macular edema or pseudophakic cystoid macular edema or something like that. So that's the reason why. But I don't feel that there is much of difference
a
nowadays.
difference.
As of now, in the present day technology, of course, the multifocal can be, if you think that it's a difficult counseling, where I show category 2, in those cases you can try the extended depth of focus lenses
course
or
we can. We
less
have an array of
diffractive lenses, you can try those. I think those are the patients who will be really happy.
Any other questions? Any other questions from the audience? So we'll have, yeah, Dr. Sai.
Srini, as a retina guy, when you have a patient with silicone oil, would you prefer a hydrophobic IOL or a hydrophilic IOL?
You mean the silicone oil stays in that for longer time?
Yeah, the patient has silicone oil, he's come for cataract surgery. Would you prefer a hydrophobic IOL or a hydrophilic
we have seen
IOL?
with the hydrophobic IOLs only, but I don't see much of any.
What's your choice?
No, it's
We are all using hydrophobics only.
it's always hydrophobic actually. It's always hydrophobic because it doesn't allow anything to stick on the surface. So that's the basic reason why
Because
we
most of the
always
time these silicone oil are only for the temporary tamponade. Only very few cases, 2 or 3% of the cases in the retinal surgeries what we do require a long term or a permanent
I think
5000
he
centistones.
meant that subgroup only, yeah. Right, if there are no other questions to be
Thank you.
asked, then I think we should sign off. Thank you so much, my coach.